OpenEMIS is a versatile open source software which supports the administration of health financing and social protection schemes. It is recognized as a digital public good by the Digital Public Goods Alliance and is listed in Digital Square's Global Goods Guidebook as an emergent global good in digital health. OpenEMIS can be downloaded, adapted, and freely used anywhere in the world. What sets OpenEMIS apart? For efficient delivery, health financing and social protection schemes require complex processes with high volume data flows. OpenEMIS is designed to manage these processes by seamlessly integrating beneficiary, provider, and payer data in a single platform. In Nepal, OpenEMIS has been used to manage the social health insurance scheme since 2016. With OpenEMIS, processes such as enrollment and claims processing have been made easier. With the Android-based enrollment app, enrollment assistants can go door to door to register households to the scheme. And a web-based claims entry reduces paperwork for health facilities, enabling the Health Insurance Board of Nepal to achieve a rapid rate of expansion, rolling the scheme out to the entire country in the last 6 years. OpenEMIS is flexible and can be customized where needed. In Cameroon, OpenEMIS supports the HIV user fee elimination scheme. The goal of the Ministry of Public Health is to remove all user fees for HIV testing and treatment, but there remains sensitivity around collecting data from people living with HIV. The flexibility of OpenEMIS allowed customization to manage beneficiaries while collecting the least possible amount of personal identifying information. Based on its modular design, OpenEMIS is versatile and can be adapted for different uses. In Nepal, in addition to health insurance, OpenEMIS has also been used to manage an employment injury insurance scheme, which offers coverage of medical expenses to workers in the formal sector following an employment-related accident. In Cameroon, OpenEMIS is being customized for voucher schemes for maternal care. And in the Gambia in 2020, OpenEMIS was adapted to manage the largest cash distribution scheme in the country's history, with the goal of protecting poor households against the economic effects of COVID-related lockdowns. OpenEMIS has been developed with interoperability as a priority, and because it is built in accordance with industry standards, can communicate seamlessly with other systems. In Tanzania, where OpenEMIS is used for the Community Health Fund scheme, OpenEMIS is integrated with other government systems, such as the Government e-payment solution, allowing beneficiaries to make convenient digital contributions to the scheme from their phone or computer. Flexibility and interoperability make OpenEMIS a sustainable solution that not only meets the needs of the current moment, but can evolve to meet tomorrow's. When a government, company, or organization starts using OpenEMIS, they join a global community and have access to the expertise and support of implementers, experts, and software developers from around the world. And the OpenEMIS community is growing. 6 years of the OpenEMIS initiative, co-financed by BMZ and SDC, has meant 6 years of expanding use cases, entering new regions, and forging partnerships. Today, OpenEMIS is used for 11 different health and social protection schemes in 8 different countries, covering close to 10 million beneficiaries. With feedback, knowledge sharing, and code contributions, members of the community are constantly working to improve Open EMIS so that more people can benefit from health and social protection coverage around the globe.
Hello to everyone. Today is the fifth session, the fifth module in the webinar series. So this is the webinar series for the awareness building on DRG and USC. And the fifth module is DRG and the health system objective. After completion of the series, so participants will be able to utilize the knowledge on the DRG to design the strategic roadmap to adopt or to update the application of DRG into the USC framework according to the respective role, and step up the experience on DRG by planning the educational learning fit to the appropriate USC status of the country. Today, the last model of the focus on the DRG and the health system objective. So that this model lead to the understanding of the DRG and the health equity and healthcare quality improvement, the role of the professional bodies and civil societies in civil society organizations to improve the healthcare through the DRG development, and the relationship of the DRG that fit with the AeHIN GAPS framework. And to remind you about the health system and building blocks, and the DRG is more or less cover the information and the financing part, and we measure all about the service delivery. And DRG and the objective of the health system by the 6 building block to increase access of the coverage, especially for the USC, Universal Health Coverage Policy. And the service provided should be of good quality. And the overall goal of the health system is to improve health equity, improve health status, responsiveness to the clients, to the people, and social and financial protection, and improve efficiency. By this 6 building block, I will focus on the access, coverage, quality, equity, satisfaction, responsiveness, and efficiency through the DRG as the tool to achieve this. Just this diagram I have shown you earlier, that within the insurance model or the universal health coverage, there are 4 parties involved within the providing the coverage. We are aiming to provide coverage to people or patients, and we have B as the provider of the system, and the insurers or the government. In the case of Thailand, the insurers, we have 3 schemes, and for the 4th party is the regulatory and the monitoring role of the professional bodies, and DRG is the payment methods that send the signals of the payment method to the provider. It's the relationship between funders and providers, and that is to provide access to the patients. The evaluation of the focusing on the Thai health care system, that we use DRG to provide the protection of the achievement of the universal health coverage, especially the high cost of care. The access to high cost of care have been achieved through the 3 insurance schemes. At the beginning of the Thai USC, the transplantation and the cancer treatment were excluded from the benefit package because of the fear of the expenditure. We cannot control the expenditure, or the expenditure will be too high. But subsequently, with the DRG payment, it allows the achievement to the roadmap become successful, and we pay on the DRG and with some unbundled item for the high cost. Then right now kidney transplant can be covered by the 3 schemes, by the UC scheme, by the CSMBS, and by the Social Security scheme. And also the bone marrow transplant paid by the DRG items, and the some of the unbundled items, and also liver transplant, for example, and most of the cancer treatment with the protocol, and the registration of the patients pay on the by item of drugs, and for the admission by the DRG. That's the access of the universal access to care. And for the DRG, whether it achieves the good quality of care, we have monitored the readmission, because we pay on the DRGs, and the length of stay tends to be shorter because hospital may not get the per diem payment, so that the tendency of the early discharge from the hospital will affect the readmission. But the monitoring of the readmission in the Thai healthcare system, it doesn't seem to increase substantially. But we may see the break of admission to get the another DRG payment for the subsequent admission. And we also monitor the research on the mortality outcomes for the quality. For the equity, with the DRG tools, we can measure the horizontal equity. Horizontal equity in terms of equal treatment for equal need. We use DRG to compare the treatment cost and the outcome of the same situation, and compare between the 3 insurance schemes, because they use DRG to pay, but perhaps they use with different base rate. For some countries, DRG is helpful in achieving the vertical equity in terms of unequal treatment for unequal need, because of different area or different province may have a different health situation or health problem. So the resource allocation formula in UK or in Australia, New Zealand may have the item of DRG in the formula of the resource allocation to the region or to the area. Our work on the access to care for the high cost care. Example here is the condition of the congenital heart disease. Congenital heart disease, it's had the connotation of the unavoidable, because every year there are babies with the congenital heart disease. If when we provide the universal coverage, all the babies are detected, and they are detected very early in their life, and the number of cases for the babies covered by the Civil Servants Medical Benefit Scheme, it's around 70 or 80 the cases within these years. And the UC scheme, the number of cases is much higher, because UC scheme covered the general population. And the graph shows that the the average age of first detected or come, the parents bring the babies, or the detection process of the babies with congenital heart disease very much earlier, especially for the UC scheme. That this graph shows that the access to care for the whole population, or the majority of population, is very good. And even the better for the UC scheme because of the significant difference. However, once the babies were detected for the congenital heart disease, they have to be referred, if they are found, the first found in the community hospital or in the periphery, then the babies will be transferred accordingly. If surgical collection is needed, then they will be treated and pay on the DRG accordingly. This graph shows that if patients were treated at the regional hospital, the mortality outcomes of the babies in the regional hospital, or this graph is for the treatment by the teaching hospital, would any differences detected in terms of outcomes by the surgical treatment, or by the severity index, by the Charles comorbidity index, or whether the difference will be determined by the sex or age and the insurance status. The treatment at the regional hospital, the odds ratio of differences in mortality outcomes are determined. The significant difference were observed for if the patients will perform the surgical condition. It's higher than the average of 1. That means sometimes surgical is indicated, but the baby face higher mortality for the surgical treatment. But it's more, we compare the mortality within the hospital or after a year after discharge from the hospital. And surgery may in a way indicate the severity of the condition. So it's the odds ratio is very high by this comparison, and the same for the severity index for the comorbidity of the condition by Charles. But male and female is not the difference. Age also significant difference. if the babies perform comfort treatment at the older age, the mortality outcome is reduced because if less than 1 and significant. But unfortunately, by the scheme also significant difference. That means the civil servants medical benefit schemes face the mortality less than the UC scheme. The situation more or less the same for the completion at the treatment at the teaching hospital, but not for the surgical condition or surgical patient. So this raised a lot of questions rather than deliver the answer. That means we need to explore further whether the inequity or disparity occur even though we are paying on the DRG and the access to care is much better because we provide the universal coverage, or in other way, because of DRG of the comparison between the same condition, but within the same condition of congenital heart disease, there are a lot of differences in the clinical condition, and clinical condition may lead to the differences in mortality outcomes. DRG and responsiveness, because of the DRG tend to have the hospital tends to have the early or the shortest stay, or what our observation for the orthopedic cases, when we use DRG to pay for all conditions, orthopedic cases see the effects of the shorter stay, but this shorter stay means that the mode of treatment seems to have the surgical intervention rather than conservative treatment. I mean, the surgical condition for the surgical treatment for orthopedic cases seems to be much higher, and that's the benefit of the patients, because the patients can go back to the normal condition earlier rather than stay longer in the hospital. So the shorter stay can lead to the higher efficiency of the hospital bed use. DRG for the efficiency because of the shortened hospital stay and lead to the high bed turnover rate, and in a way it lead to the lower bed occupancy rates. That means less crowded condition and less crowded can lead to, in a way, to the better quality, and the cost minimization and the cost containment are frequently observed by the impact of the DRG payment. The evidence from the international literature this is the literature from from China. The publications is on the systematic review of the use of the DRG in different parts of the China. By systematic review, finally they with the scrutinizations of the quality of the paper, the final number of papers included in this review is about 13 studies, and impact on the expenditure per admission seems to be very obvious for almost all of the studies. It may reduce the the direction most of the studies lead to the reduce in the expenditure per case, but some study may, that means the minority of the studies lead to the increase in expenditure per admission. The conclusion is that it can control or reduce the cost per admission, and also the reduce in the out-of-pocket payment, which is one of the objective of the health system, is to provide financial protection to the population or to the patient. Length of stay is shorter, and the quality of care it's more difficult to measure. So fewer studies reflect the study on the quality of care and the equity of care. In this, in China, it seems to reduce the equity of care. And a few studies on the upcoding of the DRG. Another paper from China as well attempt to, from the systematic review, go further on the meta-analysis. And the meta-analysis also confirm what the majority of the studies on the shorter the stay, lower length of stay. So the reduction is about 8%, and the higher readmission rates, about 1.4% increase in the readmission. So this is the main impact of the DRG. And for this slide, I show you on the first module that the impact of the policy objective of DRG payment. It's the review of the impact in focusing on the European countries. And in England, it seems to focus a lot of studies and show the impact on increased efficiency expand activity, enhance patient choice, reduce waiting lists, increase patient satisfaction, improve qualities, and can control costs. So those are the impact according to the objective of the health system. But if the DRG doesn't work well, so it's the role of the professional bodies or the civil society organizations, the roles to be involved with the development process of the DRG and the policy implication of the decision on the use of DRG. Example of the involvement of the professional bodies or the clinical experts can involve in the reclassification of the DRGs. And since the dynamicity of the condition of the treatment of the clinical conditions, so the revision of the version of DRGs should be frequent. So this in the update process of the DRG tools. Once the DRG versions has been updated, so it's up to the policy decisions whether it accept or not accept the newer version. So this political economy in terms of the change of the version of the DRGs will impact on the migration of benefit from one section of hospital to another section of hospital. So it may affect the adoption process of the newer version of DRGs. As I presented earlier, that the 3 schemes in Thailand, they are using different DRG versions because of the impact of the DRG is different. And it's also in the policy decisions also have to base on the costing of different type of hospitals, and this involved in the policy of base rate setting, whether we adopt differential base rates or have different formula for compensation to the heavy loss of the hospital according to the DRG, because DRG is the management according to the average. And the base rate is also set according to the availability of the budget, especially the USC budget that allocate whether it is for outpatient or inpatient or for the prevention and promotion activities. Professional bodies and civil societies can also involve in the audit process and the evaluation of the use of DRGs or the distortion of DRG, like DRG creeps. So the audit can prevent DRG creep. Another issue is on the transparency of the process. It will make the DRGs more sustainable for the health system. So these slides also present earlier, and it's describe the change of the version of DRGs or the conditions that needs to be transparent, that has to be published on the Royal Gazette. That means the public hearing, after public hearing, and the use of DRG will impact the public, and the public should know the information that use and have the impact on the society at large. So the understanding of all the stakeholders must be acceptable to all the stakeholders. Finally, the DRG's modules that come and fit in the AeHIN platform by the AeHIN identification of the GAPS model GAPS model, that GAPS mean the governance, architecture, program management, and the standards and interoperability. This fit these two activities on DRGs and the AeHIN come together very well, because managing on the DRG claims or payment, it needs efficient national claim systems, especially need the specificity of the claim items, and then we need the standards. And the example of the TMT or Thai medicine terminology deliver the better specificity of the claim items and the process, ongoing process on the laboratory, the order or the use of the lab tests. And further development should be on the medical record audits. I put here CDA that's used for the electronic medical record. This should help in the efficient process of the medical record audit, or the assessment of the quality of care in the future. So the standards of the data, or the so to conclude, within the 5 modules in this webinar, it's the proof that the USC policy framework is favorable for the installation of DRG. But if the USC policy framework doesn't say anything about DRG, it may not insert DRG, but as I said, the DRG that is used for the allocation of the inpatient expenditure, it's at least 1/3 of the total health expenditure. So it's quite a lot of stake on that, and if used comprehensively, it will achieve coalition or the direction of using DRG is acceptable. We need to mobilize multiple expertise to develop the team. This is the fundamental factor for success. And the groupers, DRG groupers, which is important tool for the operationalize from concept to the day-to-day operation. These tools come after the development of the classifications and calibration. That means the detailed explanation on the multiple expertise. Cost data at the macro level can be used for determining the required budget for the DRG allocation, and also for the sufficient base rate setting. Transparencies at every stage will achieve the sustainability of the DRG use, and the dynamicity of the clinical treatment or the health systems dynamics need to deliver, need to DRGs, the description of the different DRG or the clinical conditions, and this is the rather complex system that advances in the informatics or in many related fields will help us understand our complex system. Yeah. This is the conclusion from the 5 modules of the webinar. Open for discussion now. Thank you.
So thank you so much, Professor Supasit. I think we have questions in the chat box. We have several questions. Then we can start with the first question from Mr. Vicente Alberto Puyat. So he is asking, is a per capita payment system also prospectively paid to facilities to provide service package for chronic non-communicable diseases to complement DRGs for transplant cancer treatment and also high-cost service for non-communicable diseases? So maybe you can, Professor Supasit, you can scroll up the chat box. Yes, if it is easier for you.
Thank you for the questions, bringing in the concept of the per capita or the capita, like the practice in Thailand, that we have one pocket for the capitation payment and another big pocket on the DRG. prospective payment has been discussed whether it's prospective or retrospective. Some interpret DRG payment as a prospective in terms of agreement made beforehand, made prospectively, but the payment is made retrospectively. That means in once when how many patients come within a year, then in terms of account, it's it made retrospectively. But so that's the interpretation of a prospective or retrospective. But within these questions, I also want to respond in terms of capitation. We have not in Thailand. We have not put into the concept of risk-adjusted capitation in terms of using the experience of the past year of the risk of the patients, like the patients that ask for transplantation or the NCD with the multiple level of comorbidity. So the transplant patients, then they need for next year need higher capitation rate than those who not have transplantation, or the patients who had chronic, the NCD with the such as the need replacement, renal replacement therapy, then should have the higher capitation rate and than those who have not. But this risk adjusted not much incorporate into the capitation formula. We rather unbundle or make some kind of some kind of adjustment, not in a systematic way. That's the area of improvement in the future, or the area of the research.
I see. Thank you so much, Dr. Supasit. So next questions come from Realist. So I think she's asking, how do you measure readmission? How do you measure readmission? Since the DRG implementation will increase the readmission, how do you manage it?
Readmission, the detection of readmission is the subsequent admission is if less than 30 days is defined as the readmission roughly. This is the we can apply the formula to calculate readmission. But as I presented earlier, that readmission in Thailand doesn't seem to change drastically, then it it rather not being monitored. So the if it is serious, then we can prospectively, or we can monitor and make a reduction in the payment or in the audit process. But right now, we seems to neglect it, and it seems to increase the rate of admission. That means especially for the intermediate care, for the condition of intermediate care, we can observe that hospitals tend to break admissions. But another phenomena that occur within the COVID-19. I think it's still difficult to because of the chaos. It's the chaos in the information to monitor. It seems that we cannot trace very well the admission specified under the home isolation, community isolation, and also the cohort ward isolation, and so. This is in my assessment. I think it's difficult to assess this. I haven't seen much of the research that presented that they can deal with this very well.
I see, Dr. Supasit. So next questions. Is there any findings on the effects of DRG payment methods on the admission of primary care sensitive conditions such as asthma, heart failure, or diabetes in hospitals?
For some items, we can, like in the UK, they put this ACSC primary care sensitive or the ambulatory care sensitive condition into the quality outcome framework to adjust for the reward payment or pay per quality. In the NHSO in Thailand, they also put this some score as well on the quality QOF, the payment on the quality. So it's the matter of the concept that if we accept that the ACSC is the indicator for not being of good quality, then we can set the measurement system because the registration of the 13 digits that we need to trace the patients. Right now, in Thailand, the also implement primary care, the outpatient can use anywhere. So this more or less more difficult to implement this kind of concept, that because of the patients have freedom to choose the ambulatory care at any. There is no legislate, not strict, not the strict control of the primary care use, because of giving more freedom of using of the primary care. So this I think it's, they may have difficulty in next question.
Yes, so we are reaching out of time. So here's the last question, Professor Supasit. In the Thai health system, have performance-based payments been successfully implemented to mitigate undesirable consequences of DRG-based payments?
The readmission, I may tend to say that it's not, we are not being too stringent or very tightly control of the readmission or the referral. It's the mechanism. Since we have the in this way, we have Ministry of Public Health under their responsibility, and we have a teaching hospital. They use the administrative control, trying to limit the referral to the teaching hospital in a way, because of they set different base rates for the referral cases in the if they refer within the regional hospital of the Ministry of Public Health, they set the lower base rate and higher base rate for the teaching hospital, because teaching hospital don't want to have less payment rate. This the administrative rule may keep effect on the lower referral, but readmission, I tend to say that we still not putting this problem very high priority because of the imperfect payment with the DRG, and we have not a good alternative of the intermediate care payment. So this more or less allow the hospital to try to break admission.
Okay, thank you so much, Professor Supasit. So I think nearly the end of the webinar. So we have Dr. Bunchai, our AeHIN chair here. So you have anything to say for the DRG system in Thailand, Dr. Bunchai?
Thank you, Piraya, and thank you, Ajahn Supasit, for provide us the knowledge about the DRG in the webinar series. And all the record of the webinar series will be posted in the AeHIN repository. And for the all the 5 webinar will be transcribed and then arranged and edited by the GIZ and the open image to be the kind of the online learning material for you and your colleagues to come and review it further. And thanks to the open image and the GIZ and working with AeHIN to come up with this DRG webinar series. And we hope that this is not the end of the learning between the health financing, healthcare, and information system. We should have more on linkage between the health information system and the financing system and the health system in the near future. So thank you very much for all of our AeHIN member and all the audience. And good night, and see you in the next webinar on AeHIN. Bye.
Thank you so much, everyone. Good night. See you again.
Okay.